Good afternoon.
Praise be to God. I'd like to introduce you Dr. Ed Weisbart, Chair of the Missouri Chapter of Physicians for a National Health Program. He will be discussing the disparities in the American healthcare system and what can be done to dramatically reduce these inequities. Dr. Weisbart is an advocate for improved Medicare for all, a single-payer healthcare system, and has been widely published on the topic in medical journals and local media outlets. I present to you Dr. Ed Weisbart.
In October, I think it was, when my good friend Jerry Friedman was speaking. So they're good. He's quite a person. So I'm Ed Weisbart, as you heard. Can you hear me in the back? That's about as loud as I can get. Although I speak like this all the time, and my neighbors are always pounding on the wall saying, shut up. So I have my outside voice. Yes, you're welcome to come closer if you like. So I'm a family practice doctor in St. Louis. I'm from Chicago originally. I retired in 2010, but began volunteering in free clinics around 2004. So pretty much every week, I'm once or twice a week, I'm in a clinic taking care of people, typically without insurance. And I gradually came to figure out that I need to do more than just try to help my patients within an exam room. I gradually figured out that as hard as that work is to help to fight for people one-on-one in front of me, that most of the issues that people are actually dealing with are happening way outside of the exam room, and that I think it's incumbent on a physician who wants to do their job right to try to fight to get the system to change a bit. Things are pretty screwed up in my mind. So there's a lot of reason to think we can fix things, and that's what I'm here to try to talk you through. So I'm going to spend a few minutes talking about Medicare for All and what that is and how it would work. And to get to Medicare for All, we'll talk a bit about Medicare, because there's some things about Medicare folks I don't think fully appreciate. And along that course, we'll talk about something that I've read about more than I've obviously experienced, but it's the incredible injustice of how our system treats people of different color. So we'll try to explain some things that you may know, but some things you may not have realized, and how this solution, Medicare for All, would, I think, go quite a long way towards addressing some of that. So that's kind of the run of show. Is that roughly what you were thinking I would talk about? I think we'll have plenty of time for discussion too with that, but that's what I was planning on talking about. I have no conflicts of. Oh, I didn't do this. It's not going to work today. I have no conflicts of interest. I'm not paid to be here. I pay my own parking and travel. I mean, I'm just here having this conversation with you because I think this is incredibly important. And I have nothing to sell. I'm not doing anything of that sort. I do have one conflict of interest to tell you about, and I think you might accept this one, which is that a year ago I became a Medicare member. So I'm here to tell you I love Medicare. It was like getting let out of jail. It's a fantastic thing. I want to start by introducing you to my mother-in-law. There she is. And I have her permission to tell you this story, so don't be worried. So raise your hand if you agree with me that my mother-in-law is the most beautiful mother-in-law you've ever seen. Yeah. Anybody whose hand is not up can leave. So that's my mother-in-law. I adore her. Which is good, because she's like a time machine. This is what my wife is going to turn into, so good on me. Ma lives in Florida, and she's 90 now. She said I could tell you that. And she has a rare genetic problem with her heart. It's a problem that didn't even show up much until her 70s, And then in her early 80s, it was getting pretty severe. It would have killed her, but turns out that it's rare, and there's no doctor in Florida that has any experience treating this thing. But there are doctors in St. Louis, where I live, who actually focus on it. There's a team in St. Louis. So we flew my mother-in-law from Florida to St. Louis. She got world-class health care and spent probably 5 days, I think, in the hospital, and then a few weeks recovering, and then went back home. This was 7 years ago now, and she's great. She's had 2 orthopedic surgeries since then. She wouldn't be with us at this point. So, hooray. Why am I telling you this? Well, I'm the person who managed the flow of her health care, and I didn't have to get permission from anyone, except for her, of course. But I didn't have to call her insurance company. I didn't have to call Medicare. I didn't call anybody. And she, living in Florida, was able to get health care in St. Louis. That's phenomenal. You know, how many of us who don't have Medicare can do that? She can go anywhere that she wants. She didn't pay a penny out of pocket. Not a penny out of pocket. Even months later, no mystery bill showed up. She got no surprise bills. And the reason this is an important story for today is because she has Medicare, of course. She's had Medicare for now 25 years. She's never had to change it. She had to change to get Medicare, but she's never had to change her insurance for 25 years now. Doesn't have to think about it. Doesn't have to think about it. That's how it should be. She has a supplement too, which makes the premiums and copays go away, but she hasn't had to pay a penny. So if you think about messing up her Medicare, you have to deal with this. And trust me, you don't want to deal with that. I have had to deal with it. You don't want to go there. So what's so great about Medicare? Why am I focusing on Medicare for this talk? I'd say there's 3 things that people don't really appreciate enough about Medicare. The first is it gives you freedom of choice, and I kind of showed you that. 93% of doctors around the United States will see you if you have Medicare. 93%. That's pretty, and under Medicare for All, it will be virtually 100%. So freedom of choice, every hospital, actually. Secondly, it eliminates a lot of the waste that we simply have to eliminate if we want to pay for making things better. We have to eliminate the waste. And today, 34%, a third, more than a third of what we spend on healthcare doesn't get us healthcare. It's just for the insurance. And then lastly, when you think about the terrible disparities we have in racial outcomes and life expectancies, I submit to you there's compelling evidence that this would make a big difference in life expectancies. So let's talk about the waste. I'm going to show you a couple of charts that have numbers, and if they have numbers, there's a footnote at the bottom so you can tell where it's from. The footnote's too small for anybody to read, unless you're bionic. But if you want to know the source of my numbers, there's a footnote there that I can tell you the source. But here's the overhead of the insurance companies today. So the insurance companies today have a 10, 12, 15, even 20% overhead. And that's just, all the people answering the phone and data processing and saying no to you when you call. That's in the profits of the huge salaries. That's the overhead of the insurance companies. Do any of you know what the overhead for Medicare is? Good old Part A and B traditional Medicare. So 15, 20% for insurance. Well, you know this, right? Medicare's overhead is tiny. Medicare's overhead is only 2%. So if you want to get money to fund healthcare improvements, you got to get from these big, scary 15% bars of overhead down to that sweet little efficiency of 2%. And that's the smaller part of how the insurance industry wastes our money. That's the smaller part. The bigger part is that they actually have figured out how to hide a lot of what it costs to run insurance in doctor's offices and in hospitals. So the average doctor pays about $100,000 a year on staff who deal with nothing but the insurance companies. It's crazy. And hospitals, it's maybe even worse. We have 900,000 hospital beds across the United States. And I know we have 900,000 because I spent the last 5 years counting them. No, we have 900,000 hospital beds. And hospitals today employ nearly 900,000 people who do nothing but work on billing and insurance. So the average hospital could put somebody full-time, literally somebody full-time at the foot of every hospital bed to deal with the insurance functions. They can't put a nurse at your bed, they can't put a doctor at your bed, but they can put a billing person. And it's a lot of people, 900,000 people. The automobile industry, I was giving this talk in Detroit a couple weeks ago, and so I looked this up. The automobile industry, Toyota, Ford, and General Motors combined around the world employ fewer people. They employ fewer. So we have a lot of people doing this. And why do we have them doing this? The one reason we have an insurance industry, right, is to make healthcare, quality healthcare affordable to all of us. That's why we have them. That's their job, is to make healthcare affordable for everybody. How's that working out? Well, here's how Medicare does. Here's how much inflation Medicare has had in the last 10 years. It turns out, oh my God, it's terrible. Medicare has had prices go up, has had the cost per Medicare patient go up by more than 20% in 10 years. The cost for the average Medicare patient has gone up by more than 20% in the last 10 years. Sounds like a lot. Until you look at the insurance industry, where the cost for the average non-Medicare insurance person has gone up by more than twice as much. So the one thing we pay them for, which is to make quality healthcare affordable, that's the one thing, that's their niche, that's the reason they exist, and they're terrible at it. They're terrible at it. Public Medicare is way better than that. So, the more important piece, as a physician to me, is what it means for our life expectancies. So looking at the country as a whole, you knew before today that our life expectancies are maybe 3 years shorter than life expectancies anywhere else in the world, right? You knew that as kind of a dreadful thing. Our lives for the whole country are cut short by about 3 years. Here's that data, us compared to 17 countries by age. So there's a 3-year-old American compared to 3-year-old Switzerland, Netherlands, United Kingdom, Canada. Here's me at 65, Irish versus a 65-year, 66-year-old in Ireland and whatever. And then there's my mother. So get it? So we're going to be at the bottom of this because, as I just told you, we are the worst in the modern world by far. So there's the sad part of the graph. What you may not have realized is this changes once we turn 65. We turn 65, and country by country, year by year, our life expectancies become the best in the world. Become the best. So we have a lot of reason to be proud of our country. We have many of the world's best doctors and hospitals, and pharmacists and nurses. We just clearly don't let everybody in. And as I'll bet you've already figured out, the problem is significantly worse if you're black. African Americans around the country live about 3.5 years shorter than do white Americans around the country. They live about 3.5 years shorter. And what is it that African Americans are more likely to die of younger? What are the 3.5 years? What is it? What is it? And it turns out that some of it is homicide, right? So it turns out that of the 3.5 years, maybe 6 months is from homicide. And I don't need to, y'all know the issues of socioeconomic terribleness in our country that kind of explain this. But that's 6 months out of 3.5 years. The rest of it, heart disease, is much more of a driver. There's twice as much early death from heart disease as there is from violence. And then all these other things. So yes, there is an issue with homicide, and it's not trivial, but most of the difference, 86%, the strong majority of the difference that causes that 3.5 year gap is from things that we know how to treat, things that we know how to prevent. We just don't let everybody have those things, and that's terrible. And it's the worst example is maternal mortality. I don't know if you stumbled on this, but it's really dangerous to be pregnant and black in the United States. You're 3 times as likely to die if you're pregnant and black than if you're pregnant and white. And most of that difference is treatable and preventable. I wish I had this data that I'm going to show you for women, but I only have it for men. So black men, the death rate for black men since 1980 has been falling in the United States, and that I think is a reason to celebrate. That's great. Compare that though to the death rate for white men, which has also been falling. Now I'm not showing you this to show you this, it's the next piece, which is somebody looked at the death rate for blacks in 66 other countries. People of African heritage in 66 non-USA countries, and it looks like this. It looks like that. The only way to explain that is it's the United States. It's overwhelming. I don't know how to explain it, but I bet you all can think about it as well as I can. So it's unique to our country. No other modern country, 66 other countries don't do that. And a big part of it is this, right? A big part of it is this. If you're white in the United States, you're a lot more likely to have insurance than if you're black. Uninsurance in the United States is much more prevalent among blacks than among whites. And if you have insurance, the kinds of insurance you can get are quite different if you're black versus if you're white as a country. This used to be exactly true in Kentucky. I looked this up a couple days ago. This was the exact same pattern in Kentucky. And then when you all did Medicaid expansion, this disappeared. I don't know if you know that, but black uninsurance and white uninsurance in Kentucky today is the same, about 6%. I don't know about the rest of the mix issues, but at least that did make a huge difference. So we need to fight to not let anybody mess with that. It's incredibly important. So there's that. There's another little piece of this argument is that there are 3 places you can look in the country where there aren't racial disparities. One would be dialysis, right? So I don't know if you know, but for Medicare, if you turn 65, you get Medicare, right? It's also true if you're blind, if you have Lou Gehrig's disease, or if your kidneys fail. So if you go onto dialysis and you're not 65, you still get Medicare. We did that as a country 30-some years ago. So everybody on dialysis in the United States has Medicare, so that's the same. It's also true in the VA. I've never heard anyone push back and tell me that the VA has strong racial preferences in how they treat people. So the VA, if you're in the VA, it seems, from everything I've read, that you get the same care whether you're black or white. And then when you turn 65, you get Medicare, right? So what does it look like? Well, on dialysis, blacks on dialysis live longer than do whites on dialysis. Did you know that? Did you know that African Americans on dialysis actually have longer survival than white Americans on dialysis? In other words, equalize the insurance, and suddenly this whole issue changes. In the VA, blacks in the VA survive longer than do whites in the VA. Again, equalize the insurance, and this issue changes and turns 65, and that big difference in life expectancy narrows down a lot more quickly than just aging into Medicare would account for. So universal health care, I think, would make a huge difference. I'm not here to pretend that getting Medicare for all is going to end racism. That's like that's a much bigger. But to me, speaking to somebody outside of the group, one of the worst implications is that y'all die younger, and it's just criminal to let that happen. And this, I would argue, would make a huge impact on that. So what is this single-payer Medicare for all? It's basically 2 things. It's building on Medicare with all the things we were talking about, and it says improve Medicare because Medicare has some problems, and then expand it. So improving Medicare, there's a few things we need to do. It's not Medicare as we know it today. It's a better form of Medicare. So for example, Medicare today has co-pays and deductibles and financial barriers. And so 1/3 of seniors who have not bought a supplement, as I did, or have not gone into an Advantage program, which is a whole other topic we could talk about, but 1/3 of seniors have done nothing about dealing with the co-pays and deductibles, and they still declare bankruptcy. So traditional Medicare, if you don't buy a supplement or something, you're still at risk of bankruptcy. So that's the first thing we need to do when we say fix Medicare is get rid of the co-pays and deductibles. Those are they just get in the way of healthcare. They don't help anybody. They just make people have to pick between things, and you should never have to pick about your healthcare. So get rid of the co-pays and deductibles. That's the first thing that we're saying when we say improve Medicare. The second thing is that there's things Medicare does not cover, which it should. So, for crying out loud, Medicare should cover dentistry. You should be able to go to the dentist. You should be able to get eyeglasses. You should be able to get hearing aids. You should be able to go to a nursing home if you have to. There's about 15 of these things that Medicare does not cover today that we would cover in Medicare when we do this system. So improve it by getting rid of the benefit, by getting rid of the co-pays and deductibles, and expand it to dentistry and all this stuff. And then give it to everybody. Give it to Senator McConnell and his wife. Give it to. I might have to make an exception, but give it to everybody. Give it to wealthy people so that they stay invested in keeping it strong, and give it to low-income people so we don't have to have these crazy fights about expanding Medicaid. Missouri has not yet expanded Medicaid, and I struggle with this every day. So good on you that you did. But give it to everybody. Get rid of these crazy fights about income being related to it. Give it to older folks, and then they would suddenly have dentistry. They need dentistry. And give it to kids. Then we don't have to have fights about whether or not to expand insurance for children. Give it to everybody. That's not just to be nice. It is nice, but that's not just to be nice. That's the only way to get rid of those big 18% scary bars of overhead I showed you down to the 2%. That's the only way to get the savings. It's the only way to make the system more efficient. It's the only way. The public option does not accomplish that. The public option just adds one more choice. So we need to do this if we want to get the money we need to pay for all that. So it's really important that we stop letting the insurance companies scoop out a third of what we spend in order to pay for the stuff that we need. It also is not the only way, but it's probably the strongest way to get us to be able to negotiate the prices of drugs. We need to be able to negotiate the prices of drugs, which is illegal today for Medicare. We need to fix that. And I would argue that the best way to accomplish that, not the only way, but the best way to accomplish that is to let Medicare negotiate drugs. And then lastly, if everybody is in the program, if everybody is in it, then you can change jobs and not worry about changing or losing insurance. Changing insurance means finding a new doctor, oftentimes. It means if you work for the auto workers, GM, and you go out on strike, and you have a health care benefit that you gave up wages for to have that health care benefit, you will go out on strike, as UAW did a couple months ago, and the first thing General Motors did was say, hey, I know you've got this health insurance, not anymore. So they went on strike, and they lost their insurance immediately. The union backfilled a bit, but that shouldn't be on the table. That shouldn't even be on the table. So it's really, really an advantage. There are two bills. This isn't just a pipe dream. There are actually two bills in Congress, one in the House, one in the Senate, and they are very, very similar. They actually have language that's cut and paste into the other one. Same paragraph numbers. I mean, they're almost identical. There are 2 or 3 important differences. If you want to talk about that afterwards, we can, but they're very similar. First thing is both of the bills, House and Senate, talk about covering all the stuff you would think should be covered. Basically, everything that's medically necessary would be covered. Secondly, they both say eliminating the co-pays and deductibles, with one small exception of the Senate bill for drugs. That's a kind of a quirk, but basically get rid of all the co-pays and deductibles. All USA residents, you would have to reside. You couldn't just come visit for a week and then stay in the Mayo Clinic. You'd have to reside here, but you wouldn't have to be a citizen. And that's so incredibly important. If you're on the bus, you don't know who's sitting next to you. If you're in a restaurant, if somebody next to you has coronavirus, right, the new hot thing, if somebody has that, you want them to be able to go to the doctor when they're sick. You don't want them to be having to spread this because they're afraid if they use health care, they're going to get kicked out of the country. If you're a resident here, you should have health care. It's a common good. It helps me when you have health care. It helps you when I have health care. It's a common good. You need to be able to pick your own doctor. Nobody today, the insurance companies take away your choice of doctors. You want to pick a doctor. A friend of yours said, hey, Dr. So-and-so is really good. and you got to look at your insurance online or something and go, well, I'm sorry, Dr. So-and-so's not in my network. I can't go to that. Or you see Dr. So-and-so and you like Dr. So-and-so, and then your employer changes your insurance, and now you got to find another doctor. I'm sorry, doc, as my patients would say to me, this is my last visit because I no longer have your... That's crazy. That goes away under Medicare for All. Patients choose their doctors from almost every doctor in the country. It would be the rare doctor who says, I'm not going to participate. Prescription drug price negotiations and no more premiums. So if you're a Medicare patient, you're paying a premium for Part B, comes out of your Social Security, that disappears. No more premiums, no more payments to anybody. So, but the question, of course, is how do we pay for it? That's one of the biggest things we hear. Number one, we hear, I don't want to give up my choice. Well, you don't have choice today. Your employer picks your insurance, that picks your doctor. So you have way more choice under Medicare for All. Then we hear, well, how do we pay for it? We can't possibly afford it. I'm here to tell you that's a lie. That's a lie. Of course we can afford it. We spend twice as much. We spend twice as much per person as any other country in the world. We spend twice as much as every other modern country in the world. How can you tell me that as proud Americans we can't figure out how to cover everybody when we're already spending way more than anybody else? That's just, it's crazy to say that, and that's a speculation. Let me show you some facts. So there have been, actually I have to update, there have been now 30 studies, one came out last week, 30 studies that say we can afford to do this. Hundreds of economists, you met one a few months ago, those of you who were here, hundreds of economists have said we can afford to do this. This is not controversial, except for the people who are lying to us. This is not controversial. This is like climate change science, right? There's all of the science, all of the economics, with tiny exceptions, say this. So this is not the controversial part. Let me walk you through just one study so you see how this works. So there would, of course, be new expenses, but there would be new savings. And I want you to look at it like this for just a moment, because the two studies that don't agree with this did not have a green bar. They just talked about the new expenses, and they were silent or incredibly misleading about the savings. So there would be new expenses. Nobody's saying there wouldn't be, but there would also be new savings. And the new savings, every one of these 30 studies, the new savings would be at least as big, and many say bigger, than the new expenses. So of course we can afford it. Well, what are the new expenses? People would get more health care. That's not a bug, that's the goal. I argue that's the reason we want to do this. People could get more health care. They'd go to the dentist. They'd go to get their blood pressure treated. They'd pick up their insulin. They'd do stuff. They'd get more health care. That's why I want to do this. But it would be misleading to say that that's free, right? Somebody's got to pay the dentist, So most of the studies say roughly this much. They say if we did nothing else, and all we did was give health Medicare to everybody in the country, that the country's healthcare tab would go up by about 12%. And that's a number that's used on the far left and the far right, with very few exceptions. That's about the amount healthcare would go up. So, but what are the new savings? Well, the first is we'd be running one program instead of running hundreds or thousands, I don't know, of programs. And just think in your own life, it's got to be simpler to run one program than to run hundreds that aren't even keeping the cost of healthcare down. It's got to be cheaper to do this, so roughly that much. We could negotiate the prices of drugs. So pharmacy is about 15% of what we spend on healthcare. So that small number is a 6% drop into 40%. Or 40% drop into 15%. So 6%. So we would save 6% of the national healthcare expense by doing this. We would be able to get standard rates on paying for things. I don't know if you've run into this, but you can go to one pharmacy and get a flu shot in this arm for $25, or you can go across the street and get a flu shot in this arm for $100. Literally, 25 or 100, and they both make money. So there's got to be a way to, and that's not just flu shots. That's bypass surgery. That's cancer care. That's everything. Everything. The prices are all over the place based on how much they think they can get away with charging. And they all make money, right? Or they wouldn't be doing it. So there's got to be a way that we can save some money on that. And this is a pretty modest savings. And then fraud and abuse. 1% savings on fraud and abuse. Most of the studies actually say 7 or 8% savings. But my point is, you can make really conservative estimates here and more than fund the system. So how would you pay for it? That's not paying for it. You pay for it through taxes, of course. And there are dozens of ways you could do the arithmetic to pay for the taxes. You could just take the progressive income tax and make it more progressive, or you could do a complicated, I'm not expert at that, but of course there's a fair and equitable way to fund it through taxes. And at the end of the day, almost everybody in the country would spend less. You'd pay more in taxes, yes, but no more premiums, no more copays, no more deductibles, no more living in fear that you have, like my mother-in-law, some problem in Florida and nobody's going to pay for them to go to St. Louis. None of that anymore. So of course we can fund it, we can come out with a way to fund it. So what does Medicare for All do compared to the public option? You've been hearing about the public option, right? If you watch any of the debates, I'm sure it'll come up tomorrow night. The public option is this idea of don't make it Medicare for all, just make it Medicare for a few. Just a little more Medicare for people who want that, because I want to keep my choice of insurance companies. So just put Medicare, give it a price, and put it out on the market, and a glide path, Medicare for all who want it. That's what you've been hearing about, right? Buttigieg and many of the others. So how does Medicare for all compare to the Medicare for all lookalike plans? Well, first, surprise medical bills. 40% of hospitalizations today, if you have Medicare, if you don't have Medicare, 40% of the time you come home and months later you get a surprise bill for $2,000 on average. So that would disappear under Medicare for all. Put in the temporary limited plan that you're hearing everybody other than Senators Sanders and Warren, and I'm not here supporting a candidate, but everybody other than those two, put it into the public option, and you don't do anything about those surprise bills. You'll still get them, right? Because you won't have everybody in the same system. Heroin and opioid epidemics, I didn't look in Kentucky, but I'm here to tell you in Missouri, this is a horrendous problem. And you see people who are addicted, maybe they come in with or without an overdose, and they desperately want to get treatment, and there is no place to get treatment. There is no place to get treatment. Or it's hundreds of miles away, or they have a huge waiting list because it's not funded. Under this model, of course, that would be funded the same as heart surgery would be funded. It would be funded. So under Medicare for All, treatment would be available. That doesn't solve all of the reasons we have it, these diseases of despair, as they call it, but at least you could treat the darn thing, and under public option, not so much. No change under public option. Cost of prescription drugs, Medicare for All, of course, would make a huge difference in that, and eliminate the copays, public option, not so much. Reducing what we all pay, most of us would pay a lot less, public option, not so much. Women's health, if you want to get pregnant, you should be able to get help with that. If you don't want to get pregnant, you should be able to get help with that. And all the other issues covered for everybody, and not so much. Everybody covered, of course, that's the core principle, not so much. And lastly, racial disparities. I argue that it's a huge step forward. A huge step forward. There's a lot more work to do too, but a huge step forward. And there's no reason to think the public option would have hardly any effect on that issue. So why single-payer Medicare for all? Medicare and Medicaid, when they were before 1965, there were black hospitals and white hospitals in the United States. Or even in mixed hospitals, there were the black floors and the white floors. And let me tell you, those were separate and not equal. It was dreadful. Medicare and Medicaid, when that law was passed, the federal government, the big, mean federal government came in and did that terrible thing, and they said, you want our money? You stop this crap. And a whole army of some volunteers and others from the government came in and aggressively inspected hospitals, looked behind the doors, went to the kitchen and talked to people who really knew, because they were trying to game this whole thing, right? And they really went in, and that's why we don't have at least overt separated hospitals for blacks and whites. We did in 1964, and we did not in 1966. I don't know if you know that. Medicare and Medicaid, that law is why we no longer have overtly segregated hospitals. So what would this do? What more could happen if we set this system up? It's got to be huge. So what are the arguments here? I'm saying it creates freedom and corporate restraints on all of our decisions. I hate having somebody tell me what I can and can't do. It would end that. quality, a pathway. It doesn't solve everything, but it at least creates a pathway where it's in the system's own financial interest to fix this. So a pathway towards that, and it's just more fair. It's a sense of justice. So you can join our group. You don't need to be a doctor, although that's in our name, but go to pnhp.org, Physicians for a National Health Program.org. You can sign up for our emails there. They're free, or you can join us. Or if you're Facebooky, go to Doctors for Single Payer, and that's what I brought. Thanks.
All right.
Discussion?
Are you going to be around to ask?
Sure, yeah.
If there's anyone who would like to ask questions afterwards, Dr. Wiseman will be around. And so we have the room for approximately 1 hour. Is that right, Dr.?
Another hour.
Want to do it now? Why don't we just take a few now?
You want to take a few now? So we'll take a few questions now and say maybe 3 or 4 questions. That's good. And then
Yeah, that'd be great.
is there a question from the group? Question from Dr. Yober?
Yeah, I wanted to ask you, the single payer program, is it based off of a particular country formula or program? So where are we gathering information? What's your search?
That's a really important question. The model that I showed you, this single payer model, did this just come out of the blue? What do we base it on? Are there other countries that are doing this? And if so, what does it look like for them? How did we come up with this particular model? And I would tell you that you're right to ask that question. Around the world, every country does this a little bit differently. So if you look at the 15 or 20 countries that have essentially national health insurance, every one of those is different. And so what this proposal does is actually take what I think of as the best parts of each of those. It's the most similar to the system in Canada. It's the most similar to the system in Canada. And I don't know if you know, but around 1972, we didn't have managed care, right? Managed care started in 1973, and in 1971, Canada put in their Medicare for All program. 1971 is when Canada went live all around the country. So before 1971, they had the same life expectancies as we did over years. They had the same healthcare costs as we did over years. And then around 1972 or so, we went with managed care, and they went with Medicare for All. And since 1972, it's been like this. So their costs have been pretty largely flat, and ours have continued the same curve. They now spend half of what they were spending the same, now they spend half. Our life expectancies were a few months apart in 1972 and for years, and then this happened, and now their life expectancies are 3 years longer than ours. So we can do better than Canada, right? Canada doesn't cover dentistry and prescription drugs. There's things we can do better, but it's closest to Canada, and there's tons of information about it.
And then if you're home to die, socialism tries to figure out a way how they can help you. That's all I'm going to say. So capitalism would say, you don't have the money, so we're going to send you home. Socialism says, well, we're going to send him in the clinic. I think I told you the story.
Yeah.
And then the story in the clinic, so I go to the clinic. Bottom line, I ended up having a $70,000 operation, and I didn't have to pay for it because they wrote it off. That's socialism. Capitalism would send me home to die. If it wasn't for that caring hand or that caring compassion and that mentality that they call socialism, I probably wouldn't be standing in front of you now. Capitalism is to build the bank. Socialism is to help people. That's
Canada, and Canada is set up exactly like Medicare is here, right? Canada is like here. It's like Medicare. You pay your tax dollars, and then Canada, federal government pays the doctors, but the doctors are off in their own practices. So that's how Medicare is today, right? You can go to a doctor on the street, not employed by the government. He just gets reimbursed, or she gets reimbursed by Medicare. That's the national health insurance. That's how Canada works. That's how Medicare works here. There's another model which is more like the Veterans Administration, and is how Great Britain works, where instead of there being just the insurance, at the VA, the government actually owns the clinics, right? The government builds the hospitals. The government employs and hires and fires the doctors and the nurses. And that's much more like how Great Britain organizes their healthcare system. I'm here to tell you that the VA system and the Great Britain system despite all the accusations, they actually are the least expensive strategy, and they have superior results. But I don't think that's going to gain traction in the United States. That's just a bridge too far, I think, for most of us. That is socialized medicine. Socialism is defined as the government owning the means of production. So that is the VA. The government owns the means of production. That is Great Britain. The government owns the means of production. That's not at all, frankly, what we're talking about. We're just talking about moving the insurance into the background. He went to Canada, the Shouldice Clinic, to get his hernia repaired. And probably 2 days before, I don't know this, but I'll bet 2 days before he went there, he was railing against socialized medicine. And then he went to Canada and got his hernia fixed. And the reason that's a good story, aside from the injustice of having somebody do this and then have the money to go elsewhere, the reason that's a good story is it demonstrates that under a system like Medicare for All, that doesn't interfere with competition. That makes doctors compete against each other to be the best we can, rather than making doctors competing against each other for the most lucrative insurance contracts. And that form of competition creates things like the Shouldice Clinic in Canada, where wealthier Americans say, hey, there's a really world-class place 300 miles north of me, I'm going to go there. That's what Medicare for All would do, whereas today we're competing for insurance contracts. So it's a great example. I hadn't thought about that for a while. Thank you.
Good program, good program.
This event was sponsored by the Kentucky Anna for Single Payer Healthcare, Brother Wycliffe, Special Dr. Adam Garrett, Kay Tillow, Bob Cunningham, Sister Harriet, Dr. Edward, and myself. So we're glad you came out, and we hope that you have ascertained some great information. With that, I want to say something. Of all the forms of inequality, injustice in health is the most shocking and inhuman. With that, we want to remember that we do have a right, we do have a choice, and your enlightenment will help you make that choice. So with that in mind, I'd like for you to stand, and Dr. Garrett, did you want to say a word?
We'd just like to express our appreciation to the West Chestnut Street Baptist Church and all the people here. And also to Pam Haynes for Sweet Peaches for meals. Thank you.
Okay, so I'm just going to ask.
And before we leave,
I hope you enjoyed today's presentation. And if you're looking for peaceful entertainment solutions, don't forget Cornelia, Moss-Oldham, video producer. He offers affordable rates, professional results. We now have a mobile network. Senior citizen discounts are available. Book now. Contact us. Have a day filled with your favorite things.